Again, thank you for joining us tonight, and thanks to MicroDental and everybody taking time out of their Thursday night to join us on this webinar. It's going to start off with analog, the science behind why we're doing digital, and we need to know that science. And we're going to start with the analog and traditional way of making dentures. Then we'll get into the digital part with printing and milling. We're going to get started here. I'm going to give you the outline of the presentation. Again, we're going to start with traditional analog full denture techniques. We're going to go into workflow on digital cases, case design, milling and printing techniques. We're going to concentrate on a couple of different systems tonight, mostly on the Ivoclar system with Ivotion, and also the Dentsply printed system, the Lucitone print. And we'll compare it to other systems also. We'll speak about the effective communication between the dental laboratory and the dentist with case planning, leveraging digital technology in your practice and in the laboratory, and how to achieve that case predictability resulting in patient acceptance. One of the things that I find as I go around the country meeting with dentists and clinics and even DSOs and big practices around the country is the lack of predictability and confidence in making dentures because of all the office time and chair time it takes and all the adjustments. Well, it doesn't have to be like that. I've been very successful over my career with predictable outcomes on dentures, and that's what we're going to talk about tonight. So I think back on my career and how many dentures I made when I had my laboratory. I was averaging about 15 dentures per day, 75 dentures per week, about 3,300 dentures a year. And this is a small laboratory we had too. I was doing most of the work there. And so in 20 years having the lab, did 67,500 dentures. It's a lot of dentures. Now I'm probably up to over 100,000. How many brain cells killed by monomer? What was I talking about? But we don't have to worry about monomer anymore, especially with printing and milling. We have some new technology out there and new materials. So we're excited about that. So looking back in the removable technology, it took us a long time to get to where we're at now. It used to be that you go to a dental show and all you saw was crown and bridge, zirconia, implants. And now you go to a dental meeting, whether it be a laboratory meeting or a clinical meeting, and you see a lot of removables because removables are really making their way back here, and it's in big demand. And we have to keep up with that demand. So moving forward, we come across a lot of different technologies and new advancements in the industry with denture-based acrylics, denture teeth, digital dentures, partial denture materials with clear partials, metal-free partials, and scanning capabilities to improve our digital denture network and how we produce digital dentures in an evolving technology. So we come a long way. Now we have highly aesthetic teeth and unsurpassed denture-based materials. And these are just a few of the dentures I've made over the years. You can see the characterization in the acrylic and the denture base, the beautiful denture teeth, and the aesthetics on these denture teeth are amazing now. And this is what we're trying to get in digital dentures also. This type of aesthetic results with denture teeth. And now we can match the existing gingiva on the patient with denture-based stain. Look at this beautiful denture. These are with PhysioDent's teeth, and the denture base was stained to match the patient's gingiva. And we can do that now on digital dentures also with special techniques. And this is just showing staining denture base here to match the patient's gingiva. And we can mimic natural gingiva anatomy on wax, the try-ins, and we utilize artistry and various shaded waxes. And this is just a photo of one of the denture try-ins that I do in a laboratory and how they go out of the laboratory. And I get a little crazy with the characterization. But what we do, we get a picture of the patient's gingiva, and I try to match it in a wax. So I take a picture of that. After I process the case, I'll match that on the denture base also. But we have diagnostic wax ups for crown and bridge. Why can't we have a nice characterized wax up in the denture so the patient can see what that denture is going to look like when it's finished? So you see how nice the characterization is on this denture here. And this is another try-in, a wax try-in, going out of the lab here, and look how nice and characterized that is. So if I was a patient, I saw this, I would be happy, rather than seeing just I call them pink smoothies, just a pink smoothie with no characterization at all. And, but now we can print and mill accurate aesthetic dentures with amazing fit, form, and function. And we're going to speak about that a little later on. The first half of the seminar is going to be analog and traditional dentures, and then we'll get into digital dentures. So, and then, this is showing the printed Lucitone print in the carbon printer. This particular photo here, this was the first digital denture I ever did. This was about 6 years ago. And I helped, years ago, I helped develop an acrylic called Diamond D. And I brought it to market. And it's a high impact denture acrylic. And they had Keystone had come out with some pucks. And they asked me to mill these pucks and try to, bond denture teeth in and see how they worked out. So this on the right hand side, this is the first digital denture I did, bonding in Vita teeth, and came out beautiful. So this is a mill denture and one of the first ones I ever did. So, but more people need dentures now than ever before. The industry predicts tremendous growth now through 2050. And experienced denture technicians are the guides for dentist and patient success in denture prosthesis. And this is a quote by Dr. Stephen Wagner, who's a prosthodontist who helped bring that Lucitone print denture to the market. And a few years back, I was at a Seattle study group meeting in Phoenix, and Dr. Christian Coachman got up on stage. I love what he said. He said, "Professionals who understand dentures are the ones who understand smile design." And I said, "Wow, somebody really recognized us denture technicians out here." And because we have to fill an intraocclusal space of over 40 millimeters, and we have to set these denture teeth. So we better know smile design. So that's why I like to see, even in our laboratory, our ceramists and crown and bridge technicians learn how to set up denture teeth, so they can learn all the anatomical landmarks when it comes to setting dentures and setting them correctly. So I'm going to show a little bit of survey here, a recent survey that was done by the NADL, and about services laboratories provide throughout the country. So the top 5 services: crown and bridge, implants, ceramics, complete dentures, and partial dentures. And in 2021, we did a survey about digital dentures, partial dentures, digital dentures with partial dentures. And at that point, only 8% of the industry in the United States was doing digital dentures. And the rest, 92%, was traditionally manufactured. If we jump to the recent survey in 2024, full dentures are up to 21% now. So as you can see on the lower left hand of the screen. So and partial dentures are up to 23% as far as digital versus analog. And overdenture cases, about 28% of the dentures are done digitally. And then you can see veneers, sleep apnea appliances, and orthodontic appliances. But the percentage of full dentures that are highly aesthetic, standard in the economy is shown here. So 31% of the dentures produced in the United States are about standard dentures, highly aesthetic, about 29%. And if you look over to the right-hand side, you'll see a percentage of denture acrylic that is used, and still the number one way dentures are processed are by compression packed or press packed. So I found that to be really interesting. We do a lot of press packing on our laboratory also, in addition to the other technologies. But I thought to show this was a little bit interesting, just to show what's going on in the laboratory industry regarding removables. So where are we going in denture technology? Well, the United States dental laboratories are seeing a dramatic increase in full denture cases, implant dentures, and partial dentures. And this is a reflection on the overall industry. And more income opportunities for dentists, dental laboratories, dental material manufacturers, and DSOs. And when we talk about case planning and patient expectations, it's real important that the dentist should meet the mind of the patient before he or she meets the mouth. What do I mean by that? Well, we have to look at the background of the patient, and we have to do a new patient pre-clinical interview and ask, what are your concerns or limitations? And how long have you been a dentalist? How many dentures have you had since your tooth loss? And how did you lose your teeth? And when was the last time your dentures were relined? I hear so many stories about patients getting in a new denture, never even coming back to the dental office to get things checked out. Well, things change, whether it be occlusion or recession. So it's important that the patient goes back to the dental office. And have you ever considered implants? Patients who have a lot of problems with the removables, they should consider implants if they're able to get them. And then we look at our checklist. We look at the patient complaints, the history of edentalism, what kind of tissue support that patient has, the stability, retention. And I add this into it, and people ask me, what do you add the floor of the mouth and tongue room and position? Because to me, it's very important when you're manufacturing a denture to make room for that, especially on the lower of your tongue, because the tongue can trip out that lower denture. So we have to look at the floor of the mouth and tongue room and position, and also look at the ridge analysis, as you see in the left side here. And so I make, when I make a lower denture, even with digital dentures, I make a small concavity on the lingual of the lower, so the patient's tongue can fit in there and almost act like a retentive element. So that's important to look at also. Then we have to look at border extension, centric elation, VDO, phonetics, aesthetics, occlusion, and the opposing dentition. So it's very important. It's not just writing down, do a setup on a denture, full upper setup. We have to look at all the background of the patient and what the patient is going through in order to plan the case correctly. And with that, communication, we have so many communication tips at our fingertips. We have some means of communication, and sometimes we just can't plan a case correctly, because with that, we have to use the right materials and we have to communicate correctly as a technician in a laboratory with the clinician. So we look at the clinician with towards their clinical knowledge and training, the assessment of the patient, appropriate treatment planning, detailed information on the work authorization form. It's really important. We can't just have do a full upper, full lower setup shade A2. I would like to know the background of the patient. I want to see digital photography. I want to feel like that patient is at the bench with us and with us at the laboratory, so we can actually make a denture that's going to be functional, aesthetic, and it's going to last a long time. And the main thing too, we want to use quality materials and the right materials. And communication from us, the certified dental technician in the laboratory, the clinician depends on our technical expertise, knowledge of procedures and materials, and the appropriate feedback to the dentist on impressions, bites, and shades. And we own a case plan with the clinician. We want to share digital photography and, of course, again, quality materials. So when we talk about growing edentalism, more than 36 million Americans don't have any teeth, and 90% of those have dentures. And 90% of denture patients are unhappy with the fit of their dentures. Why? I mean, it's amazing that so many denture patients are unhappy with the fit. Dissatisfied or frustrated patients. They have sore spots. Occlusion is not right. The stability is not correct, and then it's a long turnaround time for the dental office and the clinician. And it's difficult to provide sometimes for good fitting dentures. I haven't had those many challenges over the years, because and I know what to look for, how to plan a case, how to use the correct materials. I see those red flags on cases, and I stop the case, and we make things right. Whether it be an impression, if I have concerns about occlusion, I communicate with the doctor for a successful case. So some of the problems with full dentures is compromised stability, poor neuromuscular coordination. We talk about occlusion, low tolerance for mucosal tissue with sore spots, especially on a lower denture, and the patient's desire for more stability and comfort. And I mentioned earlier, the comfort level of the dentist is compromised due to excessive chair time. I speak to a lot of doctors, and a lot of doctors says, I just don't like doing dentures. It takes too long, too many adjustments, but it doesn't have to be like that. There's more predictability now with the process of making a denture. And the goals for that final outcome, we want to create natural aesthetics, enhance facial appearance, compensate for that lost soft tissue, and enhance the function with the right occlusal scheme, whether it be physiological centric occlusion, lingualized occlusion. We have to pick the right occlusal scheme also, and create a denture with longevity, impact resistance, bacteria resistance, and we want to eliminate and reduce those adjustments on occlusion and those sore spots. Some of those common mistakes in fabricating a full denture: poor treatment planning, distorted impressions, inaccurate master models, insufficient occlusal records, and the poor choice of materials, and now inaccurate scans. So we have to analyze even those scans that come into the laboratory, and we communicate with the doctor if there's missing pertinent information. A lot of the, and we'll talk about scanning in a little while, but a lot of the fully edentulous scans that we get when they're scanned intraorally are missing some important information, anatomical landmarks that we need for a successful denture. So when we look at the remake factors around the country in the dental laboratories, number one is inaccurate impressions or scans. Number two is inaccurate occlusal registrations. And number three is poor shade communication, and then the wrong choice of materials. So those are the top four. I think the number one phone call I make to doctors in the laboratories is on the impressions, or scans. And we want to make sure they're correct and work with the doctor and let's get things right on the onset, because the ultimate goal is patient satisfaction. So we're going to start now with the best practices on analog or traditional full dentures. And normally it's about a 5-visit experience for the patient. And that first visit is going to be the preliminary impression. The second visit is going to be the custom tray final impression. Then a bite registration. We do a tooth setup and a wax try-in and the final insertion. And a visit can be eliminated if a functional impression is taken inside the base plate and occlusal rim at the second visit. And we're gonna utilize that technology more when we talk about digital dentures. So let's talk about essentials for a successful case. Let me go back here. So we talk about impressions, the right materials, occlusion and bite registrations, shade, all these come into play for a successful case. So on that first visit on the traditional full denture, utilize a stock tray, take an impression with a quality alginate material. And, just because you're taking a preliminary impression, we still want to make sure that all those anatomical landmarks are captured in the impression. Why? Because now we can make a great custom tray, and it's going to be more accurate, and we're going to get a better impression. And on that second visit, we're going to make that, send the final tray for the custom tray impression. And we manufacture the tray about 2 to 3 millimeters short of the border. And why are we doing this? Because we want a border mold. We want the doctor to border mold the case. And this is important in digital dentures also. When we get to digital dentures, we'll talk a little bit about border molding also. And what I recommend is taking a monophase, a heavy body material, and coming around the periphery or the border of the denture, put a little adhesive on the tray rather, and then put it in the patient's mouth and massage that into the patient's musculature. And take it out of the mouth, and then you're ready to take an impression with a medium body or a light body impression material. We have still have doctors who are using some compound material also, but most of the time we're getting the PVS material when it's border molded. So this is that functional tray with the functional occlusal rim that I mentioned before. So basically what we're talking about is making a base plate. We went a couple of millimeters short of the periphery. We put a wax rim on here, and now the doctor can border mold this, take a nice functional impression and a bite registration. But that bite registration using the functional impression with a therapeutically designed bite rim is the most reliable way to transfer the oral situation to the articulator. It really is, and it works out well for us in the laboratory. It has increased our success rate on impressions and occlusion. And here's some pictures of what I'm talking about here. So this is nice, a border molded full roll case, denture case, nice impression, PVS impression, and the doctor took a bite registration also. But if we got something like this in the laboratory, we see it's just let's see if I can highlight some things here for you. You can see over here, pressure with overextension of the tray, that's going to cause a problem. We see the tray shot coming through here in the impression material and loss of detail over here from excess saliva. What's going to happen now? I would get this in the laboratory, look at it, pour up the model, and make a new custom tray, and really ask the doctor to take a new impression. And plus, the impression material that's being used here is a polyether material, and that tends to compress the tissue a little bit more than a polyvinyl material. So I rather have a more of a polyvinyl material than anything else in this type of situation. Right, just let me hide that video panel here. And how about this impression? So this is an actual impression I got in the laboratory, and you can see this poor patient must have been choking, right? Going down a patient's throat. And if you look at the front of the tray here, it was never border molded. All that material just drifted away to the posterior of the tray. And so I see something like this, I'm going to ask the doctor to take a new impression. So I just feel bad for the patient, what they had to go through on this case here. This is a nice, beautiful impression here. We got the border mold. We got all the anatomical landmarks. So we're ready to go here. Then we pour our model in the laboratory. We box and bead our impression, and we're ready to pour our final model. So what about intraoral scanning for full arch cases? Well, scanning is possible and careful steps must be taken, and case selection is critical. You can use an indelible pencil to help with stitching issues when scanning a particular arch when there are a few landmarks for references. That helps, but cases with tissue texture and landmarks will be easier to scan, and we want to make sure all anatomical landmarks are captured. So it's still a challenge, scanning fully edentulous cases intraorally and capturing all those landmarks. So I want to mention a scan study that was done by Dr. LaRusso, and he had a specific directional scanning, he called it. And as you can see here, let me just get my laser pointer here. Like on the upper, he went from the habular notch all the way around to the other side, and then he went into the palatal area the second time, and then he went along the periphery, and then went along the periphery again on the upper. And on the lower, he did from the retromolar pad all the way to this to midline, and then he went back on the periphery on the buccal side. And he did the same thing on the other side. And Dr. LaRusso has had so much success with scanning intraorally with fully edentulous cases. So there was a study done with the Journal of Prosthodontic Research in February 2020, where they did an in vivo feasibility study, and it was on computerized optical impression taking of 29 patients, fully edentulous patients. Their conclusion was, within the limitations of the present study, the investigative scanners were not able to fully replace a conventional impression. But you know what? It's this. If you look at the scan strategy and the directional scanning they did, it was totally different than Dr. LaRusso's. Right? They're kind of going zigzag across the ridges. So it's really important. And you know what's great is iTero and Align Technologies. They're pretty much using the same type of scan strategy that Dr. LaRusso is using, and we get successful scans with iTero. So if you go to the Align or iTero website, they have PDF guides on denture scanning. Like you see here, this is the scan guide for an existing denture. And then this is the edentulous scanning guide. And if you look at the steps here, you can see it's similar to Dr. LaRusso scanning. And we've been very successful with this type of strategy. So if you want these PDFs, you can go right to their website, and they have these PDFs on there. All righty, so just some little tips and tricks there. So now we're up to the third visit, and the doctor's going to take the VI registration and occlusal records. Want to make sure that patient is in an upright position, and I'll explain why in a few minutes. And want to verify the shade of the teeth of the patient, and take those occlusal records if we're doing in full upper and full lower case, and just take those and give us the information we need on the occlusal rim with the midline, cuspid lines, high lip line, and low lip line. And so what we try to do at the laboratory, we try to contour these wax rims so you have less work in the operatory. So we're going to follow the traditional dimensions. The wax rim height from the periphery to the incisal edge on an upper is 22 millimeters, and the occlusal width is about 8 to 10 millimeters, and the anterior width is about 3 to 5 millimeters. And on a lower, we're going about 18 millimeters from the periphery to the incisal edge, and the same occlusal width and anterior width. But that wax rim is going to cover 2/3 of the height of the retromolar pad, because that's where the second molar is going to wind up. So we try to give you and contour these occlusal rims correctly, so it's less chair time for you cutting away wax and adding wax in the operatory. And there's a couple of tools we use. One of them is an Alma gauge, and as you can see here, the pin is put into the papilla here of this Alma gauge, and we're coming out on an average about 8 to 10 millimeters from the papilla when we're setting our anterior teeth. So this is a great guide to give us not only for bite rims and occlusal rims, also for denture setups. And another tool that really works out great is something called the Colbeck template. This was invented by a good friend of mine, and it gives us the width on the anterior, the width on the posterior rim, and it shows us where the 18 and 22 millimeters should be on the occlusal rim. And there's little slots where you see 18 and 22. You can stick your blade or your barred Parker in there and cut the rim and mark it there, so you know exactly the right height. So these are tools that help us in the laboratory, save you time in the operatory. So taking the bite registration, really important. And I spend a lot of time in my regular seminars when I'm talking about occlusion and setting denture teeth on taking bite registrations. Because when I had my laboratory, I was in an office building with about 10 dentists. I was constantly being called down to the operatory to work with the doctor on these patients, and I got to know what to look for and what not to use and what to use. So something like this, when we get to something like this in the laboratory, this is an actual case I received, and I'm looking at the case. I said, "What am I doing with this case here?" And it's immediate denture, and doctor took a bunch of wax, had the patient bite down. It looks like it's alu wax, some beeswax, and I'm not too sure, but I could not get the opposing model into this wax. So I called the doctor. I said, "Doctor, please, maybe we can take a new impression, make a custom tray, and we'll take a new bite registration." And then I heard the 5 words I hate hearing the most: dentists do the best you can. So, but on something like this, a case like this, we can't do. We have to do the right thing. It's going to be, we have to start from scratch, do the right thing, and get the correct bite, and maybe a custom tray, a new impression. And that's what I got on the case. So look at this patient here. This patient ready to take an occlusal registration here, and the patient is sitting back in the chair in the operatory, struggling, right? Struggling on the left-hand side to get into their physiological rest position for a correct occlusion. Finally got her in the correct occlusion, but she's still struggling. And reason why is she's sitting back and putting her head forward, and it's affecting the whole procedure of taking an occlusal registration. So we want to make sure that the patient is in an upright position. So, and we look at the plane of occlusion. Look at the picture on the left-hand side. The tip of the nose to the middle of the ear is the Camper's plane. And that occlusal plane should be equal to the Camper's plane. And so when the occlusal rim goes to the dental office, if that occlusal rim is sloping down on the posterior, we want to adjust that. So and we'll adjust that plane of occlusion. This particular picture here, there's a ruler going from the tip of the nose to the middle of the ear, and you see that occlusal plate is sloping down. So we followed the guidelines of that bite registration without trimming back the posterior. We're going to be setting these teeth almost in a reversed smile situation. So the doctor is cutting back the wax. And now you can see on the upper right-hand side how nice and even that plane of occlusion is with the Camper's plane and the occlusal plane. Doctor's marking the midline, the cuspid line, the high lip line, and the low lip line. That's what we need for the information on setting denture teeth correctly. And then we have the patient enunciate with different sounds, even with the wax rim. So we know how to adjust that, and we know where those anterior teeth should wind up. We can control the lip line. We can control the angle of the mouth and bring that out to make it look more natural and fill the patient's mouth out a little bit. So I know how that denture should look when I'm finishing that denture. In this particular photo, the doctor added on the upper left-hand side, added some wax to the incisal, so I know exactly where that incisal edge should go when I set my denture teeth. So one of the tools that we use quite a bit is called a papillometer, and we're going to be using this also on digital dentures. And usually when the final impression is being taken before we make our occlusal rim, I ask the doctor for a papillometer reading. And this is going to help us contour that occlusal rim correctly also. So this papilla reading is showing the low lip line about 17 millimeters. So we're going to come down a few more millimeters when we set our denture teeth, and we know exactly how to contour that. And when I'm contouring that occlusal rim, I can contour it to that 17 or 20, 21, 22 millimeters, wherever I need to contour it. So this is a great tool, and we're going to be utilizing that also, like I mentioned, with digital dentures also. So when we get that information from the doctor dental office, we want that information to have by occlusal rim to have the smile line, the occlusal plane, canine line, and the midline. That's going to help us set those teeth in the right manner. And we're also going to need this when we do digital dentures also. So one of the things I love is full mouth reconstruction, and I like to use a semi-adjustable or fully adjustable articulator when I'm doing these types of cases. This type of articulator is not going to do it. You don't have that intercondylar distance of about 110 millimeters that you need. The condyles are not the condyles that we have in our natural TMJ. So these are fine if you're doing, maybe quadrants or maybe one or two teeth, but I'm not crazy about these hinge articulators. Even the magnet articulators, it's the same thing. It's a hinge articulator. This is called a version 1 articulator. It has that intercondylar distance, and it's a little bit more accurate. It's a less expensive semi-adjustable articulator from Yamaha. And then you have your, Danar, Whipmix, Artex. There's a lot of articulators to choose from when you're talking about using a semi-adjustable or fully adjustable articulator. And what's great is we're going to be using a virtual fully adjustable articulator when we go to design our digital dentures. So we're mounting on a semi-adjustable articulator. I want to make sure the occlusal plane is marked to the occlusal plane the workbench, and the incisal point is aligned to the incisal indicator of the articulator, as you can see here. See how nicely that's articulated? There we go. Setting our denture teeth here right to the occlusal plane, and it's mounted correctly on the articulator. We're following a Camper's line in the occlusal plane. And this is, we look at the average length of the anteriors and the lower anteriors, 20 to 22 and 18 to 20 millimeters. So I try to visualize the patient when I'm setting denture teeth. So that's why I like digital photos when we're setting denture teeth. So this particular one here, going 2/3 of the height of the retromolar pad, setting these denture teeth. Tip of the nose in the middle of the ear is a camper's plane. And then you have your Facebook transfer. Every time I do a lecture, I have a room full of doctors. I talk about Facebook transfers, and I see doctors cringing. So I like a Facebook transfer when we're doing a fully adjustable, full mouth reconstruction. And one of my favorite articulators in Facebook techniques is with the Artex. And with the Artex Facebow, we have the 3D universal joint, a bite fork, a Facebow frame, and a transfer table. So you don't have to send that whole Facebow to the laboratory. And I'll show you why. So first thing you want to do is, say we're making a full upper and full lower denture. You have the full upper, full lower occlusal rims in your hand. You're going to put some V cuts in there, take an occlusal a bite registration, put your midline, cuspid line, smile line in the wax, and then you're going to take the Facebow transfer. So this is a picture of me a while ago. I was a little younger back then. My hair is still dark, but I was like the guinea pig with this situation when they first came out with this Facebow. And so what we're doing, we're registering the patient's maxillary hinge axis relationship. And it's for reference to correctly positioned cast on a semi-adjustable or precision articulator. And it ensures that the restoration of denture is made to the exact cranium axis relationship of the patient. So after we take the Facebow transfer, we take that 3D universal joint off and we attach it to the transfer stand, as you see here. It's a magnetic stand that's going to go on the articulator. You can attach it with putty or plaster or whatever you desire. I like to use putty; it's less messy. And then the doctor sends this whole transfer stand back to us at the laboratory, and we put the upper part of the articulator. We mount that. We'll take that Facebow off of the occlusal rim. We'll fit those V cuts where the doctor put the V cuts and took a bite registration into the upper. And now we have a perfectly articulated case with the exact cranium axis relationship to the patient. So, which is great. So I love cases like this where we utilize the Facebow. And then when we talk about digital technology, we have something called the UTS CAD, which is going to capture the campus plane and bipupillary line. And it's going to be your virtual fully adjustable articulator and Facebow. So what we do, we get the readings of this UTS CAD, we put it into the software, and you can see on the lower part of the screen here, this comes up on the screen, and then we bring in an articulator. So we have our Facebow transfer and our fully adjustable articulator virtually on the screen, and then we can do our denture setup. So some exciting stuff there. I'm a geek when it comes to this, so I love these extra tools that we have, even with digital dentures. So if we're getting to the end of this, the analog part here, I just want to talk about the fourth visit is going to be the denture tooth setup and try-in. And we want to utilize the correct teeth. So what are we talking? There's so many denture teeth on the market, and we want to use the correct denture teeth. And what am I talking about when I talk about denture tooth criteria? We want it the same size as natural teeth. We want something with high wear resistance, lingual anatomy for better phonetics, and I'll explain that in a minute. A good variety of shades, whether it be bleach shades, 3D shades, or classic shades. And as you can see here, this is one of the dentures I made with lingual anatomy. And lingual anatomy helps, especially in new denture patients, enunciate better, and it feels more natural in the mouth. I go as far as to make and mimic the patient's actual rugae, and I make a wax pattern out of the patient's rugae. I'll lay it behind the anteriors, and the patient feels like it's going to feel natural to the patient, and the patient's going to speak better. So it's important to have that lingual anatomy on your denture teeth. So we want functional cuspal inclination about 20 to 33 degrees. Why? Because it's going to help the patient chew and tear food better. And different emergence profiles for the patients. Smooth transitions from the crown to the cervix of the tooth or a recessed tooth depends on how the patient looks and what kind of mouth they have. And we want to utilize the tooth for unsurpassed dynamics of light. And I like to use a high-end denture tooth. I want the patient to look like they're not wearing a denture. I don't want it to look like their grandfather's denture or their great grandfather's denture. I want it to look natural, so that the patient doesn't have a denture and wants to look like their natural teeth. So I want to utilize a tooth that fulfills what I call the magic triangle for shade, shape, and light. And we can get this on, pretty much on milled dentures. And I'll elaborate the comparison on denture teeth from milled to printed in a little while. But how do we select those denture teeth? Most of the time I'm selecting those anterior teeth, I look at the shape of the arch. And usually the shape of the arch is the shape of the central. As you can see here, there's a shape of the upper arch and there's a picture of the central. So you can see it looks like a central. So this is how I've been picking out my denture teeth all these years. So it could be a square tapering ovoid tooth. If that arch is that shape, that's going to be the shape of the central. Tooth form equal facial form. Square face, square tooth, square tapering tooth, square face, square tapering face. And the tips of the canines are usually equal to the width of the nose, and the width of the centrals are usually equal to the width of the philtrum. So we have a lot of natural anatomical landmarks to follow when we're picking out our denture teeth here. And we look at do a cross section of the face here. We have that pupil line, which is equal to the occlusal plane, smile line, the midline, our cuspid lines, and this is all the information we need to make a successful denture setup. We want to set those denture teeth to replicate nature, harmonious and aesthetic. We want those anteriors positioned individually and parallel to that pupil line, and those lower incisal edges parallel to the upper incisal edges. Okay, then we set up posterior teeth. We want to make sure the central fossa of the teeth are on the ridge. Even with digital dentures, when I first started designing digital dentures, I had a habit of going to the buccal side of the lower and having it off the ridge. The first 3 or 4 dentures I designed were like that, and it's not going to be stable. So you want to make sure the central fossa of the teeth are on the ridge on the lower. Check your curvus B, which is from anterior to posterior, and check your curve Wilson from buccal to lingual. Okay, so we want to align those occlusal surfaces towards the center of the cranium. The only time I don't do that is when I'm setting a lingualized occlusion, and I want that lingual cusp of the upper going into the central fossa of the lower, offsetting any stress on the implant or on the ridge. So there's your curve of Wilson, and there's your curvus B. All right, and there's a nice harmonious transition to the posteriors. Your final setup here, final wax up for try-in. Which would you prefer, the one on the left or the one on the right? So I would say the one on the right. Okay, so this is a nice characterized wax up. And now we're finished. We're finishing the denture now. Everything looks good. The doctor sends back, said, finish it, dentist. We're going to a finish. Let's check for fit, form, and function. And the doctor wants to check for pressure spots and equilibrate that occlusion on the final denture. So when we talk about denture processing, even with digital dentures, we want a natural look, a low shrinkage factor. We want flexural strength, color, fit, and stability, and a variety of gingival shades. So whether it's traditional, printed, or milled, we want high impact resistance and that flexural strength and natural looking shades like you see here. Right? And we want a great bond between those teeth and the denture base. And these are some dentures I made with the Diamond D acrylic. This is the final denture, how natural that looks in the mouth. We see the concavity on the lingual, the lower denture here. And now we're ready to get into digital technology. So I call this the great challenge. So we're going to compare printed dentures and milled dentures now. And the great challenge is I put this because on the onset of digital denture technology, we had a lot of mindsets out there that didn't want to change. So what happens when you don't change? Things stay the same and you're not successful. So this was the great challenge. So we want to move in the right direction. Digital and analog. We want to apply the science from the analog over to the digital side with successful cases. And I call this the digital transformation, preparedness, production, and profitability in the digital world. So you want to create a more personal and predictable service for your patients, and we want a predictable service for you from the laboratory standpoint, and build that intelligent design platform. We empower our technicians. You optimize your operations and transform your digital offerings for a successful case, engaging your patients. So all this comes into play for a successful case. So when we talk about digital and analog, we still need to utilize the same fundamental prosthodontic processes to make a digital denture, as we always have. The clinician still needs to communicate and provide the technician with the necessary information for a functional case. Digital denture technology is still evolving and improving at a rapid pace. So that basic knowledge of prosthodontic principles, including providing accurate impressions, is even more important in the digital world because we can see more details now on a screen, which we could not otherwise detect before. And dentists still need to understand the importance of capturing those accurate maxillomandibular records, vertical dimension, and centric relation. And technicians need to continue to analyze ridge relationships and then select appropriate anterior and posterior teeth for the desired occlusal scheme. And even though our software picks these denture teeth out for us in the when we're using our software and designing our dentures, it's not 100% correct at all times. So I'll get into that a little bit more in a few minutes. So you look at the workflow comparisons. Traditional workflow, 5 visits, we mentioned earlier. On a digital workflow with existing dentures, we can cut that down to 3 visits. So that first visit, the doctor's going to take a wash impression if the existing denture is in good shape, board and mold it, take a wash impression, take a by registration, scan that by registration, and scan that denture. You can send us the STL file. We could also scan it at the lab with our desktop scanner. But if you send us those scans, the second visit, we can send you a printed try-in. And that third visit can be the final insertion. So the biggest pushback I think I received when I started doing digital dentures was on that printed try-in, because you saw my try-ins before, how nice anatomical and beautiful they looked in the wax. Well, we couldn't do that with the printed try-in because it was pretty monolithic. And I even had doctors trying to stick hot spatulas in there to move teeth around, which we couldn't do. But there's a way we can get that looking natural, those try-ins, and make it look aesthetic. And I'll show you that in a minute. So we're talking about a new denture. It's pretty much the same amount of visits, unless, on that second visit, we can take that by registration and that functional impression, and we can cut out a visit. So let's talk about fabricating a printed denture. We're going to focus a little bit tonight on the Lucitone print. That's where I have my most experience, I think, with digital dentures right now. I've tried some of the other systems out there, but I feel really comfortable on the Dentsply side of it with the Lucitone print. But let's talk about how we fabricate printed denture. So we have to navigate our choices with 3D printed materials. If you go to a meeting now, I was just at the Boston Yankee Dental meeting and looking at all the different 3D printed materials out there. There's so many to choose from, but we have to look at the science behind these materials. And like I mentioned before, about even with the denture-based materials in the traditional side, that is also applied to the digital side also. So which materials do I use? There's so many out there. You have Formlabs, you have Keyprint, Dentsply, Haygears. Then you have, the newer ones. Ivoclar is coming out with a printed material. Key Denture from Keystone, they're coming out with that at the midwinter meeting. That's a new one coming out. Kulzer has a new material out too. So it can get confusing, So and then Stratasys also has theirs, and there's a bunch more that's out there on the market. So my choice for printed dentures in this order are like Dentsply, Trusana, Flexera, and Haygears. Those are the ones I find I've gotten the most accurate and success and aesthetics results out of. So you're looking at Trusana. I mean, they have a great tooth resin. It's 57% stronger when it's wet. Isn't that something? And there's other materials, they're printed materials, they actually get stronger with the moisture in the mouth. Isn't that amazing? So, and the denture base impact resistance on Trusana is 10 times higher than the ISO standard. So it's a great material. And I think we have one of our laboratories in Rochester using this system now too, and they're really happy with it, the Trusana system. And it's more wear resistant. It's 2 times more wear resistant than PMMA. And then Desktop Health is on the Flexera. I like this material also. They just came out with their Flexera Smile Ultra, which the flexural strength and the impact resistance is increased quite a bit. And you want to look at that water absorption also. That 1.96 is right in the ballpark. If you get a little bit over 2, you're in good shape. But look at that water absorption too when you're looking at materials. So one of the problems we had with partial curing on the printer with printed dentures, because First, you're partially curing these dentures, and then you're either bonding teeth in here in the denture base, or you're milling out or printing and then bonding those teeth, or bonding carded teeth. But sometimes when you take that out, it's not full. Most of the time it's not fully cured because you have to put it in the post-curing unit. So be careful how you hold those dentures, especially on a lower. Those support points on the printed parts can create inaccuracies. You want to make sure the support points are in the right place when you're nesting your dentures. So printing success depends on the experience and consistency of the user. So printed case processing, we have talked about digitation, case design, the printed try-in, and the final printed denture. So in that order. This happens to be 3-shape here. We scan the model for the final impression, and that's a new denture, and we made a bite registration, occlusion registration. I sprayed some scan spray on here, and then we're ready to scan here. And this is courtesy of Dr. Ben Oppenheimer. And you can see that the doctor put some dimples in the model too, just to align it correctly. So that scan there with the occlusion registration is going to go back and merge into the original file, and we're going to start designing our denture. So the versatile articulator, it allows for centric and lateral extrusions, saving the dentist's valuable chair time. So we look at this like this is a single arch case against natural denture teeth. So this versatile articulator comes into play and adjusts all those different points. So now we're either going to mill these teeth or print these teeth, and we're going to bond this into the denture base. So digital articulations, the impressions are digitally articulated to the bite registration using special software. And there's a few different softwares out there with Exocad or 3Shape. And that digital tooth setup is placed to follow the arch shape. Remember I talked about before, the arch shape? They're applying that science to this also when we're designing our denture teeth and a tooth setup. And usually we do a full arch denture setup all at once. So what took us 45 minutes to an hour to do before per arch is taking us, a lot less time now. The vertical height can be adjusted in the software to open or close the bite if necessary. There's that full arch setup here. The software proposal and reasonable can be modified using the software tools, and I'll show you some of those tools in a few minutes. And utilizing the software, every aspect of the digital waxing can be adjusted. So I can actually put my carvings in there, my cuspid eminences. I can put stippling in there, and when I print my final denture, I can get all those carvings in there, and I really have little work to do and very little polishing, and the case is done. And there's completed denture design here. And as you can see here, now we're ready to print our try-in. So this is the monolithic try-in. It comes in various shades now, but say if something goes wrong with the try-in, so if the midline's off, you can mark it with a Sharpie. The bite's off, you can take a new bite registration. Even if the denture is loose, if the try-in's loose, take a wash impression, and you can scan it, and we can now redesign that case and print another try-in for you. So this is an actual case that we did in the laboratory a few weeks back where we did a printed try-in, and the doctor tried it in. The occlusion was off, and the case was kind of loose. So the doctor took a wash impression and a new bite registration. We got it back into the laboratory, and we printed a new try-in, and this is what we're ready to go with, a new setup and a new try-in here. So, and it really takes very little time to do that. So there's your printed try-in, like I mentioned earlier before. Big difference from the wax try-in that you saw earlier, right? So the doctor's still going to check for occlusion and phonetics. And what's happening now, we're having a lot of the patients go home with their printed try-ins just to get a feel for how the retention is and how the occlusion is for maybe 1 or 2 days, and coming back in the laboratory, and then coming back to the dental office rather, and then the doctor can make the adjustments and send the file back to the laboratory and we can adjust it on the software. But how can we make a printed try-in look more natural? Well, there's a couple of ways to do that. We can use denture-based stain, which is expensive. It's going to take a long time to do it. Or we can use aesthetic colored wax. And this is what I use most of the time. I'll take this colored wax and come over to try-in, and it looks more natural in the mouth. So, and then my all-time favorite is this new product from Harvest. It's called Easy Gum. This product is amazing. I just did a seminar over at one of our labs in Kentucky with this material, and it takes literally minutes, and it comes in strips, right? So it comes in all these different shades, and you take it off, you put the bonding agent on, put it across the buccal, and start carving around the teeth, and within minutes, you can have a nice characterized denture. And you can do this in the final denture also. So this is a great product here. It comes with modifiers, and you can really get crazy with this and with the aesthetics on this material. Then we're ready to print the denture. So we already scanned the design. We did our try-in. After we do the partial print, we wash and recycle, which we're washing it with isopropyl alcohol. And then we're ready to fuse and cure. So we're going to either cure denture carded denture teeth in there, milled denture teeth, or we're going to be bonding printed denture teeth. So there's the printed setup here. We have the support removal here, and now we're getting ready to bond these denture teeth into the denture base. So the 3Shape design software has the characterization points to set to indicate the retromolar pads, canine points, and ridge points, and that coupled with the use of Pound's triangle allows the software to pick the mold for us, so there's no guesswork. But every once in a while, I have to pick those, change the molds that they suggest. So Dentsply has their IPN digital denture teeth. You can use those. There's a lot of mold choices here. You can use those to bond into the denture base. We have to condition the teeth with something called Fuse 1. Then we bond them into the denture base with Fuse 2. And light cure about 10 seconds. I try to do 2 or 3 teeth at a time. And then we use Fuse 3, just fills in those gaps that we missed with the other material, like interproximal gaps. And then we post-cure it for another 20 to 30 minutes, cut off the supports, and then we polish the case. And there's your finished printed denture. So now, if you want to print denture teeth, Dentsply and the other companies have their own denture-based resins. Lucitone has their IPN tooth resin and their denture base. And when we're printing our denture teeth, after they're partially cured, we remove the supports. And with a carbide burr, we open up the interproximals. We paint Fuse 2 into each socket, bond those denture teeth, and then we apply a 3D sealer and post-cure. So pretty simple here. And there's your denture tooth there. We cut off those after the post-cure, cut off those supports, and there's your final denture. So just as a little comparison, you see on the left-hand side, we have the carded teeth, the traditional teeth, and the printed teeth on the right-hand side. We're still not up to par with what we had with the carded teeth. Let's put it that way. So we're getting there, though. Okay. Again, on the left-hand side, carded teeth, and you see on the printed teeth, a little more anatomy and a little more aesthetics with the carded denture teeth. Okay, now we have inkjet technology, also printed dentures, which is, it provides capillaries and opacity and colors with pigmented dentures. So that's what we have. Meyerson TrueJet X3 and the Stratasys is doing that. And then, as far as the features and benefits of printed dentures, I mean, there's a lot of positives to it. Reduced chair time, little to no adjustments, and we always have that file if anything goes wrong, and peace of mind with that final denture outcome and more predictability. All right. And also, we talked about the moisture in the mouth before with something called the BAM factor on this Lucitone print material. It increases this body-activated material, the joules per square meter, and doubles to the resistance to breakage. It goes from 1,500 joules per square meter to 3,100 joules per square meter, which means it's a stronger denture once that patient has it in the mouth. So pretty cool. So that's a little rundown on printed dentures. We're going to get into milled dentures, and that'll be the final part of our seminar. I know I'm running a little behind. Just give you another 10 minutes here to go through this because I have some good information here. And we're going to talk about the Ivotion denture and Ivoclar here on milled dentures here. So this system is a really good system. We use it a lot in our laboratory, and you can cut down those patient visits almost by 50% on some of these cases. It's for single dentures, full upper dentures, full lower dentures, implant dentures. Yes, there's so many different things you can utilize this Ivotion for, and it's a great denture. So I'm going to talk a little bit about the simplified digital denture workflow here, and it's similar to the workflow that I talked about earlier, on the printed denture. So that first appointment, we're going to take the preliminary impression and a pupillometer reading. And then we're going to fabricate the base plate and the occlusal rim. And when you send it back for that second appointment, the doctor's going to take a functional impression by registration, send it back to us. We're going to scan, design, and print to try in. And the third appointment, we're going to try it in. And if everything goes well on that fourth appointment, we can give you the final denture. So there's that functional try-in here. We can send the patient home with that. And we can see if the occlusion's right, if the fit is correct. And if not, we can always adjust it and take a new wash impression and adjust that occlusion. So this is the monolithic process with iVotion, and this is utilizing their shell geometry. It's pretty unique. So half of the puck is with tooth material, and the other half is with the gingiva material. There's a special iVotion tooth library that we can utilize. And the tooth setup is already connected to the shell geometry. But the trick is to position this correctly in the milling machine. Otherwise, it takes a little bit of practice and know how to do this. Otherwise, you'll have more pink than you want or more white than you want. So, so as we're doing this, you can see the puck here. It's highly cross-linked, comes in various shades. This is the preference shade that was pretty popular with Ivoclar's injection system. So this is pretty much the most popular shade for the denture base. And this is the tooth in this iVotion disc in position here, right in the middle. So this shell geometry was based on collected data from proven full dentures, as you can see here. So all this information was taken and helps us with the design of the denture. And this is showing it being milled on a PM7 milling machine. And for the upper and lower jaw. And here you have it here. So you can see how this is milled here. All we do is cut out the supports and we're ready to finish the case. And it was utilizing one puck, one mill. 38 millimeters, and that monolithic type of denture, not as translucent as you would with the traditional denture teeth, but I'm going to show you something in a minute with a different technique with the Ivoclar and iVotion denture. So there's your final mill denture. So I want to show you some of the problems. This is an actual case we had to the laboratory, and it wasn't positioned correctly in the mill. And you can see, look at the white on the palette on the right-hand side and the white on this flipper. So we're going to have to remill those because just wasn't positioned the right way. So sometimes you'll come across this, especially when you first start out when you're designing these types of cases. There's your completed iVotion denture right there. Excellent aesthetics, great shape, anatomical shape, and surface texture on the teeth. Minor limitations. Sometimes you'll have dentures that you just don't have enough room. You have a difficult case like this, just not enough room here. So, sometimes we can't do the iVotion case. We might have to go with a milled denture tooth and then a milled denture base. So this particular case was kind of difficult, and I didn't like the way it came out. You could see how stubby and short these denture teeth are. So in this particular case, we would go back and mill those denture teeth and make it look a little more aesthetic. So every once in a while, you come across a case like this. So the second process is called the oversized process. And what we're doing here is more flexibility. We're going to be milling denture teeth. The same denture, it's going to be milled out of the same material that the traditional denture teeth are made out of. We have the iVotion base in different shades. And then we have the iVotion multi, which is different tooth shades. And then with the iVotion Dent Multi, we can actually adjust the translucency of this particular material. As you can see here on the right-hand side, all we have to do is raise or lower the puck in the milling machine, and that'll give us more or less translucency. And there's your mill. This is the full arch mill. Look how beautiful that is. And we bond that into the denture base. Multi-shade concept. Nice aesthetics. Cross-linked material. And then we bond it in with something called the iVotion bond. And it's a great bond between the denture base and the denture tooth material. There's just some features and benefits. It's a monomer-based material as opposed to the printed material is not a monomer-based material. So this is when you're bonding it in, it is a monomer-based material because the milling the denture base is a denture acrylic, so it bonds really well with it. So the software allows for complete control to change the shape of the denture teeth, as you can see right here. We can bring it down into occlusion, Widen the occlusal surface. So a lot of things we could do with that. So let me go back. I think I missed something there. No, here we go. So excellent aesthetics on this material. So I'm going to show this on the screen here. So we have the denture teeth on a card. Half of these denture teeth were milled, and half of them were traditional denture teeth that you find on regular carded teeth. I'm going to put a line through the midline, and just take a look at it. See which side you think is milled and which side is the traditional denture teeth. It's hard to tell. So on the left-hand side, there's the Evotion dent. Those are milled teeth. So you can see the aesthetics are beautiful, really nice. And they take their the tooth libraries from the existing denture teeth that they sell on the market, and they apply that over to the digital side. So as you can see this puck here, you can see all those ripples in there. That's when we talked about the oversized processing. So this is not fully milled yet. So after it gets to this stage, we take it out of the mill, we bond the denture teeth in, put it back into the mill. And with this type of procedure, it's actually 8 times stronger than a traditional analog denture. We can control the uniformity of thickness and thinness on here. Accuracy of the fit is amazing. Minimal deformation. Expansion and contraction are like right on the money. So so it's a lot of things you can utilize. And nowadays you're able to use this with different milling machines also on the market. Amon Gearbach and Sirona. So they come a long way. It used to be just with PM7. Why have ocean dentures the same way? It's pretty much the same reason why we have printed dentures. 50% fewer patient sessions, good suction, fewest pressure points. We always have that file if anything happens to the case. Here's some testimonials by Dr. Baba and Dr. Edher. They've been using Evotion for a while. There's some key opinion leaders in the industry. And the aesthetics are beautiful. And this is just a short video I want to show you. Oh, before I get to that, let me just show you. Yeah. So these are the aesthetics with the dentures here. And then it's getting to the point where I'm being asked not even to put a post dam in the denture anymore for these milled dentures because the fit is so intimate. So usually we put a post dam. I like to put some sort of post dam in there, some sort of post dam in near that posterior region. I think it's the old denture technician in me that wants to do this, but it's not necessary. So take a look at this upper and lower milled Evotion denture here. So Dr. Lucelli from Ivoclar is trying these final dentures here. And you can see how nice they look, going to lateral excursions, making sure there's no interference. He really takes his time looking at this. And well, he takes out that lower denture out of the mouth. What do you see? Well, it's actually suction on a lower denture. You'll see that in a second here. But the bond for the denture base is phenomenal. And it's just, it looks aesthetic, functional. Trying to get that lower denture out of the mouth now. Look at it. Look at that suction in there. That's pretty good. There we go. Finally got it out of there. And look at the upper, trying to get that upper out. Look at that suction on the upper. Amazing fit on these milled dentures, really are. So, then he's going to try to break the seal, take it out. There we go. So real quickly, I had about a minute more. I just want to touch on immediate dentures. There's a special article I wrote last year for IDT magazine on immediate dentures. If you get a chance, go to the IDT website. It's Aegis Communications, and there's a PDF on my article here. But I just wanted to apply this to the digital side here. And we really want to communicate when we're planning our immediate dentures. Just explain to us on a lab script that the patient wishes to replicate the existing tooth position, or if a new position is desired. So we don't have to do a complete reset when a tooth needs to be removed, like we used to have to do when we did it on the analog side on a model. We just highlight the tooth, we move it on the screen, and we'd extract the tooth. And extracting teeth, like we used to call it model surgery, taking this off the model, we used to grind these teeth down, and it was messy and a lot of work. All we have to do now is highlight that tooth, disappears. We do our tissue contour and bone contouring with the tools and the software. It works out really nicely. So we do quite a bit of immediate dentures in the laboratory with on digital dentures. So it's just a nice way to do it, and it's easy to get a scan when there's existing teeth in the mouth. and it works out great. So just quickly, cast trimming for immediate dentures. I apply this over to the digital side also. They're not cut below the gingival crest, and I want to make sure that terminal 5 millimeters of labeled gingiva should be trimmed so the denture gingiva doesn't appear too thick. Okay, so this design for immediate dentures is simplified also by using a pre-prep scan. So if the patient wants to use their existing denture position, natural teeth position in making an immediate denture, we could do that also. We have something called a pre-prep scan, as you can see right here. So a lot of great tools at our fingertips here with digital dentures. I'm excited. All these years in this business, and I'm still excited about with the technology where we're at here. So can we make a better denture? I believe we can. I think the technology is evolving for the better. Between a clinician and a digital technician, we're going to come out, we're coming up with some great dentures for these patients here. And this advancement in denture technology is just going to enhance to achieve the ultimate goal of patient satisfaction.
We have started trying digital dentures. We have had great fits with the monolithic try-in, but then the final flops right out. Are you finding these issues, or with your choice of materials, is this less of an issue?
There could be a choice of materials. We're not finding that. We're getting feedback. The results on the mill dentures, I get that once in a while with printed dentures. On the results on the mill dentures, I'm getting phenomenal fits. Really, it's like there's really no problem at all with suction. Every once in a while, with the printed denture, I get a call that the suction was not as good. But I would say 90% of the time, I mean, over 90% of the time, we're getting great fits on a printed denture also. So look at your materials, look at your settings on your printer, and make sure, everything looks is accurate. And that could have could be an issue. And, if the try-in is good, the final denture should be fine, but if you're getting some discrepancies, I would look at your materials also when you're using.
I've had a lot of fractures of the denture base with the PMMA puck dentures. Have you seen that as well? Can conventional relines be done on PMM dentures after healing bone remodeling?
Okay, so the PMMA, so he's using the PMMA. Yeah, the PMMA dentures are, talking about the PMMA material. I'm thinking that he's talking about just the shaded PMMA, like they're using for temporaries. That's not as strong as the final denture base that we're using for printed or milling. So I've heard fracturing on the PMMA because of the stress fractures in the mouth, especially on full arch cases, and even with like all on 4, all on 6 cases, I'm seeing fractures on that. So I would try to if you're doing a digital denture, try to have either a milled denture with with a milled denture teeth and bond those in, and that's going to be the best bet. But for strictly a PMMA puck and utilizing that for the whole denture, you're going to run into some problems as far as stress and breakage.